the center of the optical zone was one of the main causes for blurring the vision that they described from them. 3% of those patients hyperopic had residual refractive error. Myopic patient who had spherical equivalent minus 0.25 to minus 0.5 were more satisfied in near and distance. 90% of them, of those patients, achieve our satisfaction parameter in uncorrected distance visual acuity and uncorrected near visual acuity. 2% of those 10 patients, of those 10% had their visual axis shifted from the center of the lens. 8% of those patients had residual refractive error in spherical equivalent of plus. Patient who has scotopic pupillary dilatation between 6.5 and 7 millimeter preoperatively had night halos more than the others, and this persists more than 3 months. And those patients, in spite of that, the manufacturer company insists that apodizing effect by manufacturing this lens and the apodizing phenomena that they put it in this lens, sorry for late, but that's what we can do, it will definitely reduce the effect of the halos, but that's what I found it in this study. Those patients were as follows: those with halos, 20% of them were myopic patients and 3% of them hyperopic. Those patients had halos which persist more than 3 months. These figures include uncorrected distance visual acuity and uncorrected near visual acuity, and halos considered to be lower than the concerned published studies. Conclusion: the optical quality with this type of IOL, diffractive, was particularly affected by tilted and decentralization and pupillary reaction. Patient satisfaction for uncorrected near visual acuity was affected by the preoperative and postoperative refraction. Patient satisfaction of uncorrected distance visual acuity was affected by residual refractive error and decentralization. Patient with scotopic pupillary dilatation more than 6.5 had high chance to develop night halos which persist more than 3 months. Thanks. I'm very sorry for that.
Any questions from the audience?
So if I can conclude what you were saying,
yeah.
Did you purposely target a little bit of hyperopia for your hyperopic patients and myopia for your myopic patients?
Yeah, well, that's
was that
the
your target
near point for them is being assisted.
No, I'm just asking the question. Was that your target? A little bit of hyperopia for hyperopic?
That's right.
And a little bit of myopia for
No,
myopic?
it's not the target of this study. That's part of this target, because we are saying that those patients should be assessed preoperatively for pupillary dilatation and scotopic and photopic. So patients more than 7 millimeter photopic should be excluded, and patients less than 2.5 millimeter for photopic should be excluded. And second thing, after 3 months, I found that those having scotopic pupillary dilatation pre-op, they persist having halos more than 3 months. So I decided to stop doing any multifocal for those patients. But 3 months later, they came back with full satisfaction. And then I did this scotopic pupillary dilatation for them. And then I found that their pupillary dilatation is reduced to 6.5. And all of us know that. Pseudophakic patients, we have a lot of difficulties dilating their pupil. So here I need to say that pupillary dilatation play a role in halos. But more than 7, I had few patients that, no, till now they have, especially those they are driving at night. Second thing, decentralization is very important to assess it in this patient. So I'm not advising any doctors doing this surgery on GA or local anesthesia injection without